Hello, I'm Dr. Anil Guri, consultant in reproductive medicine, surgery, and assisted conception. And today I'm going to deal with another case which was seen by me after a woman had had about 2 years of treatment. The topic of this discussion I call How Thin is Really Thin. We talk of the endometrium. We talk of a thin endometrium which may not be thin at all. So let's come to this case. A 37-year-old lady who was treated in 2 clinics and had frozen embryos. For about a year, she was being treated for a thin endometrium. The cycle started with using a long downregulated protocol, after which Proganova was given at about 8 milligram, and the endometrium did not progress beyond 5.6 millimeter. This was continued for a cycle or 2, and then the downregulation was cancelled and a new protocol was started. The new protocol again gave Proganova at 8 milligram. This treatment was continued till day 14 and 15, and I don't have any scans for this because they were done at another center, and the documents reveal that the endometrium did not increase beyond 6 millimeter, though it was trilaminar. Eventually, after increasing the dose to 12 milligram per day, the endometrium continued to thin, and at about 4 millimeter, the cycle was abandoned. This patient was asked to see me in my NHS practice, and there she had been labeled as somebody having a thin endometrium. Now, I'm very skeptical on women who have not had infection, who have not had surgery, who have not had fibroids. Why would somebody have thin endometrium? I believe that in medicine, we create thin endometrium by our medications. I also believe that the closer you move to nature, your chances of pregnancy will be much higher. In frozen cycles, that's exactly true. There are women who do very well with a downregulated cycle. There are women who don't like downregulation and do much better with a medicated cycle, just starting Proganova. Some women don't do good on Proganova, and some women do better on estrogen patches, bypassing the first pass effect. Some women don't do better on external estrogen at all and do better in stimulated cycles. How do we find that out? And that is essential, that you can, to a large extent, avoid women who have iatrogenic thin endometrium. So what did I do in this case? I asked her to come for a cycle tracking. And in cycle tracking, we got her endometrium to 8 millimeter without any intervention. But when? We got it when follicular size had reached 25 millimeter without an LH rise. It means, again, look at 2 of my earlier talks. Take it out of your head that ovulation occurs at follicle size 18. Ovulation can be triggered at ovulation size 18, and that data comes from IVF. It does not come from nature. Nature, we know that ovulation may occur between 18 and 30. And also, endometrial increase is linked to late follicular rise. That's something which you have to understand. That will change your management in a large number of cases where you're seeing a thin endometrium. So let's focus on this. So in this next cycle, I said that I'll demonstrate that the endometrium is better. So I put her on 5 milligram letrozole from day 2 of a cycle to day 10. Where is this protocol from? Don't ask me. It is my protocol. I work with different protocols. I do not believe in fixed protocols. What did the natural cycle demonstrate? It demonstrated that natural estrogen was the best stimulant for endometrium, and delayed onset of an ovulation trigger or an LH rise probably gave the endometrium its best chance. Natural cycles are more troublesome in terms of their input into trying to find out when you can trigger the endometrium before a spontaneous LH rise occurs. By day 13, day 14, her follicle had reached 25 millimeter with a 9.6 millimeter trilaminar endometrium. And a transfer was planned with a trigger and transfer done 7 days after the trigger. This treatment worked. The reason again is that I was willing to move away from fixed protocols. I was willing to realize that natural estrogen worked better. Letrozole does a couple of things. Letrozole allows for lower LH levels. Letrozole also demonstrates that the amount of the integrin levels as well as the factors that look after implantation and the implantation window are preserved well and increase well. And trying to combine these drugs may give us a much better outcome. The reason of this lecture is twofold. One is move away from those fixed protocols. Move away from giving high doses of estrogen. They don't work. I do not go beyond 6 milligram of Proganova. I don't think it's needed. The higher you give Proganova, you switch off the pituitary much often in a non-downregulated cycle. And that's important to realize. It's important to realize that Proganova too has an effect on the pituitary. Sometimes you don't stop ovulation with Proganova. These are the factors which we need to think about. And I would suggest that have a rethink about your thin endometrium. And believe me, in about 90% of cases where there is no pathology, you will not see a thin endometrium. Again, I would suggest share this video. See that you can spread the knowledge, educate your juniors as much as you can, and other colleagues, discuss cases. That's one way where you can always get better. Thank you very much.